Good morning. Happy Monday, everybody. Welcome to Reducing Death from Substance Use from California Bridge. My name is Elizabeth Keating. I'm the Clinical Program Director for California Bridge. Thank you so much for kicking your week off with us. Go ahead and pour yourself another cup of Monday morning coffee. I am very fortunate today to be joined by California Bridge founders and principal investigators, Dr. Aimee Moulin and Dr. Andrew Herring. Aimee, go ahead and kick us
Here.
off. We are a program of the Public Health Institute and very excited to tell you about the future of substance use disorder treatment in California.
Welcome, everybody. Thank you so much for joining us. And I kind of wanted to start here and to talk about like where we've been and where we are going and what I think we can achieve together. And this is our mission. All people deserve rapid access to addiction treatment. And I think this is what centers us as a program. And this is what brings us all together here today. This is the mission that you have all been on for the several years. And I just wanted to give you a shout out for what you have done and what we've really achieved together as we move forward into the future. Great to see you. Next slide. This is the bad news, is that there is so much work to do. And we have just seen overdose deaths continue to climb in our communities across California and really across the nation. And so now is the time that we need to come together and continue our push and continue our mission to make sure that everybody, that we're reaching everyone who needs treatment has that access to treatment. And so this is really just that push for us to keep going, to keep our mission and to keep working together so that we can solve this overdose crisis. Next slide. This is actually where we are. And I feel like as much as we have expanded access to treatment and been focused on this for several years, we are just scratching the surface. So this is national data looking at the number of people, the percentage of Americans who need substance use treatment who did not receive it. And this is 94%. So the vast majority of people with a substance use disorder are not getting treatment. And this is inclusive of opioids, alcohol, stimulants. But really what this shows me is we are just scratching the surface and there's a huge need out there. And we should all push ourselves to continue to expand that access to treatment. Next slide. And here's the narrative, and I just want to call this out. This is really the narrative that's out there, that 95% of people who are not receiving treatment, it's because they don't want it. And this is the narrative that's out there, is that this is from the National Survey on Drug Use and Health, that people don't want treatment. And how does that feel to us at California Bridge? This is the work that you are doing every day. And you and I both know this is just not true. Next slide. What we have seen and what we have proven together, your work and what you have done in your hospitals, in your communities, has shown that low threshold, easy access to care drives demand for treatment. And that when we have shown this together at California Bridge, when we were able to go out into our communities through our emergency departments and provide that low barrier, rapid access to treatment on demand, people want our help. And so that narrative that people do not want help, that people are resistant to care, we have shown together that it is just not true. Because through our work, you have shown that people want help. We just have not designed a system that works for them. Next slide. This is what you have done. So this is our California Bridge model. Low barrier treatment, connection to community care. And I want to pause here and recognize our amazing substance use navigator team for providing that warm connection to care and doing the hard work in the communities to make sure that everybody has access. And we've embedded that culture of harm reduction into everything that we have done. So this is our pillars of the California Bridge model, is low barrier treatment, community connection, and embedding the culture of harm reduction in everywhere. And that model, we have seen success. Next slide. This is what you have done through your work with California Bridge, and what we have achieved together, I think, is truly remarkable. 300,000 people in California seen for substance use disorders. 241,000 people identified with opioid use disorder. 96,000, almost 100,000 Californians started on MAT. We've also distributed almost 200,000 naloxone kits. If you look at these numbers, what we have shown together is that low barrier access to treatment, when we ask people, do you want help? Can I help you? They often say yes. And a little bit of newsflash, we did a study. 85% of the people that we approached in our study in emergency departments and asked, do you want help? Said yes. That flies in the face of the data that says 95% of people don't want help. So what you have done through California Bridge is show that people want our help. And that, I think, is one of our greatest achievements, is to show that our low barrier model works. Next slide. So we're just getting started, because remember, there's a huge need in our communities, and we have shown together that we can reach them through that low threshold model, and we need to keep on going. Now is the time for us to come together and to continue to push to expand treatment in our hospitals and in our communities. We need to expand our hospital programs and then really expand the availability of treatment in our communities in order to meet that need and really stem the overdose crisis. Next slide. And so our goal really is to reimagine the delivery system that works for people. And so that everyone, when they feel that they want help, because we know that they do, the system is designed to meet their needs. The system is there for them. We're going to take what we have learned through California Bridge about how to engage people into treatment meaningfully and apply that to the system. And this is what we're hoping to do together as we move into the future. Next slide. Here's what we've learned. And this is what we know in medicine, the core components of treatment, of healthcare treatment. Medications are the mainstay of treatment, particularly for opioid use disorder. Counseling, social supports are helpful when appropriate, when people want them, when they feel that they need their support. We want to be able to provide it for them, but really to make sure that neither one of these pieces is presented as a barrier to medications. Because what we've learned and what we've shown is that medications are really the key, particularly for opioid use disorder. And so we want to make sure that in no way are we not providing that low barrier, rapid access to medications as part of our treatment. And this is true across healthcare. We want to be able to address social determinants. We want to be able to support people to access their medications through that low barrier approach. But really, medications are the core support that needs to be in place. Next slide. And this is really the data. We know that buprenorphine and methadone save lives. Our goal through all of California Bridge is to save lives. And we know that people with opioid use disorder in particular have a 400% increased risk of death without medications. And so our focus has always been on how we can drive people to medications and that we can provide that access to them in a low barrier way that works for them. I'm going to pass it off to my colleague, Andrew Herring, and thank you so much.
Thank you, Aimee. That was fantastic introduction. So just keeping moving with this line of thinking, the current state, is that we've so underfunded substance use disorder care. County systems that have been asked to take care of hundreds of thousands of people with just a fraction of the funding that they actually need. So we're seeing these very, just a reality is when you have underfunded systems, they end up creating barriers to limit the folks who are coming in because there's huge wait lists. So we've developed this scarcity mentality where with this tiny underfunding, right, for this huge need. And so barriers are throughout the system, and they're thrown in there for lots of reasons that have nothing to do with the deep core intent of all of us throughout the medical and substance use disorder treatment who want to bring care to the hundreds of thousands of people in California who need it, because we want to save lives and improve families, improve quality of life. So what we see is that we see long distance to treatment, long wait lists. There are stringent requirements or eligibility testing at multiple steps along the trajectory. And then there's this sort of creep around coercion and contingency around court-appointed and more coercive, almost carceral kind of approaches. We saw what happens with that, and it means you reach a very small number of people. Next slide. Contrast that, and just advance the slide. Contrast that where you actually look at the need out there. And this is something that I really look to our leaders at the federal and state level. There's a fear, because deep down, I think it's pretty obvious that this is an entire segment of behavioral and medical care that fundamentally has not been developed by government, by healthcare. It's a piece of the health system that just is not there. It's not that we're saying we're gonna make everybody work a little bit smarter, faster, better. No, this is actually true capacity building in an unprecedented way for treatment of substance use disorders, with a whole new set of clinical tools that work together with traditional substance use disorder treatment to meet this unprecedented need that has arisen based on what's happened in the United States, being precipitated primarily through the opioid epidemic. So this means tying together jails, emergency departments, federally qualified healthcare centers, street teams, shelters, substance use disorder treatment programs, opioid use disorder treatment programs that offer methadone, residential treatment, all of it, tying it together, really mandating an integration and funding it to success, not funding it to survival. Next slide. So how are we going to get people into this system? So this means we're working with the jails. We're working with technology like telecare, which can drill into almost any setting. As a physician, you can do a televisit if someone's in the shelter. You can do a televisit in the street. You can do a televisit in jail. There's really no limit to the reach that you can address through telehealth. And then following through with this basic idea of respecting preference, respecting self-interest in this sort of social behavioral economics that we're kind of used to in so many aspects of our own life, where you seek something because you see that it is of benefit to you, that it's easy. And so engineering a system that is intentionally easy to use and not sort of built in with these ratchet points of testing of eligibility and such, but is smoothed out to basically make initiation and continuation of treatment the easiest thing you could possibly do. That makes it easier than going back to the street and texting your street dealer who can be at your house in 5 minutes. Making it beneficial and easy is the key. And then how do we bulwark that core achievement of initiating treatment with addressing social needs, the basic things of housing, a sense of positive future, a sense of positive economy and job, all of these things that are so essential to make a treatment initiation stick. Next slide. So this is basically our vision, is you have an evidence base of addiction medicine, which combines medications and other medical tools with behavioral and psychosocial approaches in a braided approach that sees no daylight between them two. They are one and the same. This is founded in low barrier treatment that we're seeing really, this is the standard of care. It's not an aspirational. Low barrier treatment, as SAMHSA has just published, is the standard of care. You do that in a community setting, right? It's linked with community and partnership and navigators that really do the hard lifting of bridging those gaps that are there structurally. And doing it all in this culture of pragmatic compassion, where you don't hold out, tests for whether or not someone deserves treatment. At any step in time, you're just looking to move them away from harm and towards wellness in any way you can with any tool available to you. Maybe that's counseling, maybe that's a safe injection gear, maybe that's methadone, maybe that's buprenorphine. You don't really care. You're agnostic. You're just trying to engage in any way to move them away from harm and towards wellness, with the faith that if you keep doing that with every interaction across every setting, every touch point, that group of people is going to move into sustained treatment engagement and remission. This brings together hospitals, primary care, drug and alcohol treatment programs, and every other touch point. I call this ecosystem of survival. Next slide. So within this frame, I think that we see that the ED is not to be thought of primarily as the last resort, but it really is a 24/7 federally mandated access point. So there's a lot of discussion around avoiding unnecessary ED visits. I would reframe it as an emergency physician. What I'm looking for is, how do I create value? So when I see somebody, how do I generate a long-lasting impact on the patient outcomes for that person? That justifies my salary. That justifies the expensive hospital. It's value. It's not some predetermined idea of like, what's emergency? It's value. There is nothing under the sun as valuable as starting buprenorphine or methadone in someone with OUD. We know that if you offer this to 10 or 11 people, you will see that one of them, which is a huge proportion, will stick in care for continuously for 180 days. For those of you who know medicine, that's a number needed to treat of 9, which is incredibly potent. There's basically nothing we offer in the emergency department that comes close. We're there. The lights got to be on. If you crash in the car, we got to be available to you. So it's this fixed cost that's there in the community, and we're just driving it towards improved value, right? So this is absolutely in the core of what the ER should do. And then we're using our linkage infrastructure, next slide, to pull this in to this coordinated piece of care, so that you aren't just starting someone and sending them off into the void. You're connecting them to substance use disorder treatment programs, to methadone programs, to clinic-based programs, to residential programs. And no one is ever turned away. Next slide. So what this does is it creates this ecosystem of survival that is enhanced at every touch point across jails and ERs to provide this 24/7 MOUD medication initiation system. And the navigators link this to the existing traditional specialty SUD system. And so the overall experience is just tremendous growth in patients coming into treatment of all different types, and is what really drives us to be looking for ways to fund all aspects of this system, from the substance use disorder treatment programs to the FQHCs, to the ERs, to the inpatient, to the jail. It all goes together. Next slide, and I'll pass that off to Aimee.
Harm reduction is healthcare. Just let me say that again. Harm reduction is healthcare. This is one of the radical ideas that California Bridge has brought to the healthcare system. Through your work, we have distributed hundreds of thousands of naloxone kits and changed culture to recognize that if we cannot meet people where they are and provide them the treatment that they need, we're not doing our jobs. And so no longer is it acceptable to say to someone, if you cannot participate in whatever rigid treatment protocol at this moment, I'm not going to provide you anything. And so really the key to harm reduction is to meet someone where they are, but not leave them there, and to make sure that we are providing them whatever they need, what fits into their needs, to keep them alive and to move them towards recovery or a better place. Next slide. So we're going to come together and propose a radical idea to reduce addiction deaths by 50% in 2030. And I think that we can get there, because what you have shown is that the public health problem of overdose is solvable, that addiction that we know is treatable, and that people want our help. And so our challenge is to just make it accessible. Harm reduction is healthcare, and to design our system with that mentality in mind. Expand the capacity of our ED programs. You are doing amazing work, but we know that we're not reaching everybody, and we know that there's more need out there, and we're just scratching the surface. So we need to expand the capacity of our ED programs and work to maximize the success of the outpatient treatment programs, to bring this model of low barrier, harm reduction centered treatment outside of our emergency departments and into the treatment community, so that we are incorporating this ethos of harm reduction into all aspects of care, and to make sure that we don't leave anyone behind. We know that there is a huge volume of people out there who want help, and we just haven't been able to offer it to them in a way that they can accept it. And we know that they're out there, and so that is our challenge. And I think that we can achieve this goal by providing that treatment on demand and re-envisioning our healthcare system. So our push from now on is to expand those programs, maximize the success of outpatient treatment, incorporate harm reduction, and really to push our policy leaders to shape CalAIM to meet our treatment and equity goals on the ground, in our hospitals, and in our communities. Next slide. And I'm going to pass it over to Elizabeth to talk about next steps. And thank you so much.
Thank you, Aimee. We need your help. Aimee, Andrew, and I are just 3 people, and between the 3 of us, I think we have about 7 full-time jobs total. We need your help to go out and tell members of the California policy community what is happening at your hospital and what is happening with your patient population. We need you to help us educate state policymakers about how treatment in the ED makes health outcomes better for patients with addiction in your community. We are here to help you tell this story because we are so proud of the work that you have done in the hospital setting. So I want everyone who is on this webinar today and everyone who might be watching it later today or later this week to take a moment to go to the link that we're going to share in the chat now and also in the post-event materials to find this very easy 2-page guide to contact your state senators and assembly folks. So these state policymakers, I have met with several of them. They are very, very smart, very, very well-meaning, and care a lot about your patients. But because of the breadth and depth of their jobs, they might not know about the amazing work that you're doing at your hospitals, but they want to hear about it. So use this guide that we created for how to contact policymakers. Tell them about the innovation that you have been able to implement thanks to help from California Bridge. Tell them about the number of patients that your providers have started on buprenorphine. Tell them about the naloxone distribution that has increased harm reduction in your communities. Tell them about any innovative ideas that you have, clinics you're getting off the ground, and what support that you need from California Bridge that they can help keep funded. So we want you to do this, and then we want to hear about it. Tell us those things too. We love bragging about you. It is our favorite thing to do, is to brag about the success that you have had in your hospitals. So take a moment sometime over these holiday weeks, contact your local district offices, and then share it with us. If you are fortunate enough to get either a meeting or a site visit with these state policymakers, we want to help you prep. We want to use your data from the Bridge Navigator program to help you get ready to educate these policymakers and make the case for ED-based treatment for addiction services. We want to hear about what is working. So thank you so much for joining us today. Reminder, I'm seeing a lot of comments in the chat about folks who are not prescribers sharing feedback that they sometimes have challenges with their prescribers. We have this incredible resource called California Bridge Academy, which is meant for those prescribers. This is free. I'll say that again, free, $0 CME that providers can use to both learn about our model and also qualify for the CME that they need to do to maintain their DEA licenses. So this will also be sent out in the post-event materials, and I really encourage anyone who is having any trouble with provider engagement to offer this resource to providers, because not only will they get to learn some of the California Bridge magic sauce to providing addiction treatment, but they also will be able to get that CMA that they need to keep their DEA licenses. So please join us. Tell us your stories, contact your legislatures, share the California Bridge Academy with providers who want to learn more about this treatment. So a couple of questions that are coming up in the chat for Aimee and Andrew. The first one that we've gotten a few times, can you define from the California Bridge perspective, what is treatment?
I can take this one. If we, for those of you who haven't been listening to us for the past several years, we are medication people. We believe strongly in the efficacy of MAT. And by that, I mean buprenorphine and methadone. So for us, we feel very strongly that the bulk of the evidence is towards medications. Buprenorphine and methadone save lives for people with opioid use disorder. And so that is one of our major pushes. Is by treatment, we mean medication and low barrier access to medication treatment. However, harm reduction is healthcare. So I also think naloxone distribution and ways that we can engage people wherever they are and to help them move towards that ideal state of steady access to medication treatment and social supports, counseling, if that is helpful for them, is that ideal state. And however we are able to move them in that direction, that's what we mean by treatment. Andrew, I don't know if you have anything to add there.
Yeah, I think that, there's so much behind that question. I think it's a really good one because there's many different definitions of treatment and they get interchanged in policy conversations. Personally, I really sort of like this voracious concept where you're looking for whatever tool there is that moves someone away from harm and towards wellness. That can be, as Aimee mentioned, harm reduction, that can be methadone, that can be anger management, that can be learning how to avoid cues and triggers in your community, that can be a safe, clean place to sleep and be away from people who are using drugs so that you can begin thinking about what you want to do away from such triggers. To me, it's all of those things. And that there is a tendency to peel off siloed components of that and then put them in competition. I really look forward to a imagining or a vision or future where these things are together driven by patient preference and by patient outcomes.
So Andrew, another question for you first, and then Aimee can add on. We have time for about 2 more questions. For ED docs who are out there working and saying, I don't want patients to come every couple of weeks looking for a prescription of bupe from the ED, but the patients are connected to MAT clinics, face barriers, and then say, it's easier to come back every 2 weeks to get my scripts from the ED. Talk to those providers, talk to those patients, talk to the people who are in those in-between roles.
Sure. I can speak working with, at least 30 other emergency departments outside of California for 4 or 5 years in a really, really intimate way, recruiting people who are using opioids into treatment, as well as over 280 hospitals here in California. This idea that there'll be a big rush of people seeking care in the emergency department that will overwhelm its resources is simply not happening. We can just take it off the table. It's not a theory, it's not a hypothesis, it's not a guess. It's real. It doesn't happen, period. So that's reassuring. At some level, it's disappointing, right? I mean, I want to see people coming into care. Then
I
right?
tried really hard to overwhelm my emergency department with people seeking buprenorphine and just have not been able to achieve it.
Right, exactly. So the other piece I would drive back again is value. If as it's really putting on my ER hat right now, we are in a existential crisis where there is a fundamental disconfidence in the value of emergency care outside of sort of traditional things, heart attacks, car crashes, etc. That huge ambulatory, not like this sort of inappropriate visit idea. Well, this is something that no one, not the payer, not the hospital, not Joint Commission, no one will doubt the value, the long-term value to medical systems and to society of initiating buprenorphine or methadone in someone with opiate use disorder. It's a home run. So from a very, kind of almost distasteful but realpolitik of like what is going to help sustain the perception of value, which leads to funding for emergency departments, it's really leaning into things like this that leverage and produce long-term positive patient outcomes.
Thank you, Andrew. One more question. And before I ask this question, which I think really gets to the point of why we held this webinar today, I want to draw awareness to the number of questions in the chat about the nuts and bolts of the various types of MAT. The goal of this webinar today was to talk about our policy vision for the work. We have really amazing accessible trainings about what MAT is. Maybe we can send the most recent Back to Basics Buprenorphine 101 training out when we send this recording out. It's about 30 minutes long, very accessible to both clinicians and non-clinicians. And I really recommend that anyone asking specific questions about how treatment works clinically to watch that. So for Aimee and Andrew, when policymakers say this all sounds amazing and I want to see this work continue, but there's a pending budget deficit in the state, how do we fund this?
I don't think we can afford not to expand access to treatment. If you look at the consequences of untreated substance use disorder in our communities as a driver of inequity and social consequences, I don't think we can afford not to meet the needs of our community, particularly with ever rising overdose deaths.
I couldn't agree more. I mean, I wish that in 1996, Purdue Pharma didn't begin the marketing of OxyContin and proceed to expose the US population to a historically unprecedented 265 billion MMEs of opioid per year. Something that's literally never happened on that scale in human history. There is nothing I wish more profoundly did not occur than that, but it did. So what we did is we flew that plane up to 30,000 feet, taking opioids to a level never before seen in human history. And then we freaked out. We realized we were doing a really dumb, dangerous thing, and we solved it by turning off the engines of the plane. And it just crashed, right? It was a ridiculous thing to do. We didn't think like, oh, what about those millions of people that are opioid dependent? How do we compassionately, scientifically land this plane so that each one of them can go from being dependent or with addiction to being stable and productive and in remission living in the community? We didn't have that thought. And as a result, 110,000 people died of overdose last year. So we are playing catch up on a truly unprecedented and massive scale that just demands determination and leadership. This is not time to penny pinch. We need to act, or we're just going to see an entire generation of people die.
Thank you, Dr. Herring. Thank you, Dr. Moulin. And I want to thank everybody in the chat. There's been a robust conversation in the chat, sharing advice for each other for how to bring those resistant folks in your community, ranging from providers to other folks in the treatment landscape along on this journey. So please help us, contact your policymakers, help us compassionately and scientifically land this plane of the overdose crisis. We look forward to supporting your programs well into the future. Have a great day, everyone.
Thanks, everybody.
Bye.
Bye.